other people could take a seat so we can actually get started. And this is a very exciting day for us, the Forum for Collaborative HIV Research, which is actually located in Washington, D.C. But we're affiliated with UC Berkeley School of Public Health, and we're also part of the UCSF CFAR, and so it's a very exciting day for us to be co-sponsoring this conference with you all over here. So this is just going to be a brief welcome and introduction, and I wanted to talk a little bit about the forum for those of you who haven't worked with the forum before. As I said, we're a Washington-based organization. It's a public-private partnership with the mission. It's a very simple mission to enhance and facilitate HIV and viral hepatitis research by bringing together all the relevant stakeholders. So we work with industry, government agencies, academia, community, foundations, etc. And we've been established since 1997 and have worked on many, many different research issues in both HIV/AIDS and viral hepatitis for the last couple of years as well. And as I said, we bring together all of these different stakeholders to jointly address issues in HIV research that need to be pushed forward. So this is just kind of the model of how the forum works. Everybody has a place at the table, and everybody has an equal place at the table. It's not that any one of these stakeholder groups actually runs the show. Everybody has an absolutely equal place at the table, and the idea is to work with each other, collaborate. The ownership issue is that the forum is owned by all of the stakeholders, and we're independent then from any one of the stakeholder groups. And this is just a slide that illustrates our main members and partners that we work with that are either on the forum's executive committee or on the viral hepatitis committee that works. And as you can see, we have a whole list of basically any agency that has anything to do with HIV/AIDS, including the department, HHS, and the VA. OGAC, USAID is involved with the forum. And from Europe, we have the ANRS and the European Regulatory Agency. A whole range of different academic networks and partners, foundations we have worked with, professional societies, and many industry members that work in HIV or hepatitis C drug development, a whole range of community advocacy group, and also health insurers. So to get to today's conference, the goals of the conference are to document health disparities in the Bay Area and HIV/AIDS, whether local or regional. And we really thought it was important to drill down into the region here rather than just talk generally about health disparities, really talk about what does it mean to this region. Highlight innovative ways in which disparities are being addressed, generate novel ways to address health disparities, and generate increased and productive interaction between community-based research and academic centers. So throughout the conference, we've asked the moderators to always keep these goals in mind and steer the discussions with the panelists in the direction of these goals. And we've tried to put together a real interdisciplinary approach, illustrated by this graphic, and also illustrated by the people that are here from a lot of people from San Francisco, a lot of people from Oakland, from San Jose, and from many of the other regions around here. And I've kind of got the sense that some of you have actually never really met with each other or gotten to know each other, so this is an excellent opportunity to do so. So in terms of just having representative from all of these different regions, but also different disciplines, and you will see that as the program evolves. We have a very busy day today, and anybody who looks at this would say you're absolutely crazy to pack so much into one day. But we knew that with this group we could actually manage it. So we'll start with an overview of the epidemic in the Bay Area, again an interdisciplinary approach. We'll have a panel on interventions to increase testing and linkage to care. We will have a special address on training a diverse workforce. We'll talk about interventions to increase retention in care. We'll talk about where we are with prevention, research, and then interventions for substance use and mental health. And I've never been at the conference where theater was part of it, and not only do we have one, but we have two theatrical performances that we really look forward to. And then we finish off this evening with the poster networking reception. Now remember, the reception is part of the work, so please stay and continue working throughout the reception. And then tomorrow we will address issues of federal policies and the impact they have on the state. We'll have another panel discussion on social context and community engagement. And then we'll finish up by a very thorough review of, where are we with health disparities research in this area? Have we actually addressed the conference goals? And then we will adjourn. So as I mentioned, a lot of this will be panel discussions. There will be a few lectures or presentations, but what we really want to generate is a lot of discussion where everybody is participating. And I did want to point out we are web capturing this, so your questions and everything will be part of what will be part of the web capture, and then the recording will be available on our and the CFAR websites. I wanted to also really thank the people that are flying in from the East Coast to be with us, Grant Colfax, who is no stranger to you here, Greg Millett, and a very special welcome to Dr. Joan Reed from the Harvard Medical School. I wanted to also give Eddie Machtinger a very special thanks because he really made it possible to have Rodessa Jones and the Medea Project performance happen today. And thanks to NIDA at the NIH for sponsoring the program book. I wanted to thank the forum staff. And Rob, where are you? Stand up. Rob, you've all had lots of emails from Rob. He is the team lead on this project. And Sarah Grant, who's not able, thanks Rob. Sarah Grant, who's not able to be here. She is back in the office, helped a lot with the website and the communication. But we also have Ben Hauschild. See here? Stand up. Andrea. Stand up, and Catherine Burmaster here from the forum. So there she is. If you need any help or would like to know more of the forum, and of course we also have Winnie Wang, who is here at Berkeley. Winnie, if you can please stand up. Winnie is our only full-time employee who is actually located in Berkeley. And I wanted to mention the fact that we have 2 interns here just to let everybody know that we do have an internship program, and we're very, if you're interested in having interns come to Washington, please let us know. I wanted to thank Informed Horizons, Margie Poole and Kirsten and David Poole for the excellent job they have done in setting this up, and Nancy Glick from MSNL, who has done some press work on this and will write a press release after this. And then, of course, huge thanks to the organizing committee who helped us develop this, and then the many members of the scientific planning committee who were very involved in setting up this conference. And finally, I'd like to thank Paul Volberding and Warner Greene for their leadership and inspiration for this, and welcome them up to the podium to say a few words.
Thanks, Veronica. This is an interesting room. It can be configured in many ways. I've seen it with risers in the back, and this with the poster area in the back is kind of a nice setting for what we hope is a really interactive 2-day program. Let me give you a little bit of a background. Warner and I really completely co-direct the Center for AIDS Research, and we think about the center a lot and how it can be an effective way to help bring people together and support the community of HIV research in San Francisco. As we wrote our recent recompetition, you have to recompete the grant every 5 years, we thought we had been doing a really great job in almost all areas, but we didn't think we had done such a good job with community engagement. It's not that we're disengaged, but we hadn't really done anything that we thought was special. And in thinking about doing that, we approached 3 organizations to help us carry out different aspects of re-engaging with the community. One was Project Inform, which does a great job. It has for decades, literally, especially in the MSM community, especially in San Francisco. at getting research information back and forth between the community and academics, we approached a Science and Health Education project. It's part of UCSF that provides help for science instruction in the public schools in San Francisco from kindergarten to through high school, and with an effort to think about what we could be doing to help both share more information about HIV, using HIV as a model that young people might very well be interested in science, but also in terms of trying to help the pipeline of a more diverse health and science workforce at the point where it's probably most productive, i.e. in kindergarten, almost literally in terms of growing that important force. And the final group, not the third one that we thought of, but the final one that I'll mention is the forum. I've known Veronica for a long time, and it just happened to work out that the forum became part of the University of California through their operations in the district called UCDC. It's a part of the University of California system-wide, and invited Veronica to partner with us, knowing what a great job the forum has done for years at a very broad scientific discourse. I've worked for over 30 years in HIV in San Francisco, a lot of you know, and my focus at first was pretty much on HIV here. And the early epidemic that we saw at San Francisco General Hospital was heavily in the MSM community, largely white, largely middle class, well educated. That was the first wave of the epidemic. By the time I left 11 years ago from the general, the epidemic here had broadened considerably. But about that time, I and many others of us working in HIV became aware of and involved in, interested in AIDS in Africa. And we saw a compelling need. We saw the opportunity to do amazing things, and that effort is still needed. It's still going on. But I think along the way, we kind of jumped over the fact that there was a much more diverse, much more challenging epidemic than we had seen early on right here at home. And as many of us have gotten more involved in global health, we realize that, that we have to bring that home, that we have to find ways to not ignore the disparities in our own populations, even while we still are engaged in other parts of the world. And we see this program today and tomorrow as an absolutely central way to start that process. This isn't the end of it, it's the start of it. And it's really encouraging, as Veronica said, that people come from really all over the Bay Area, from Orinda to San Jose to Marin, and obviously here in San Francisco and in the East Bay. So I really think maybe the most important thing here is the networking that can happen. Getting to know each other, getting to share ideas about how the various communities in this room have begun to address this issue. I also really think, as we have with AIDS in Africa, that the work with HIV can be kind of the foot in the door for broadening the health agenda beyond just HIV. It's not that people in Africa just have HIV. It's not that the people in the Bay Area just have HIV. There are a lot of other needs. And there are people here from UCSF who are very engaged in a broad range of medical topics affecting the Bay Area. And so I hope that this can be a model for other similar symposia that address other chronic health care needs of the Bay Area. So I really look forward to the program. I'll end by thanking Sarah Burke, who is our CFAR manager, in particular for helping put this together. It takes a lot of work to do this, and like you, I'm just eager to hear the discussions. Thank you.
I think I'm the last welcomer Welcome. It's great to have you in San Francisco. I've been asked to make a few comments about the role of basic science in health disparities research. There's no question that basic science around HIV has played a key role throughout the history of the epidemic. It, of course, has helped create now over 30 medications that have transformed the lives of individuals with HIV infection. Similarly, is helping with new approaches to prevention, pre-exposure prophylaxis, certainly the microbicides, the success of these agents. We can't probably claim circumcision as a basic science intervention, but of course the holy grail of all of prevention research is an HIV vaccine. And for the first time in the last couple of years, we've witnessed the hint of an effective vaccine. As Paul was mentioning, certainly am struck by the HIV/AIDS in the United States, despite the fact that there are more than 60 million infected, 30 million dead from this epidemic. It is actually the fourth most serious epidemic to ever inflict its toll on humankind after the bubonic plague, smallpox, and the great influenza. This is number 4 and rising. Yet it has fallen off of the awareness here in the United States. There really is, everyone thinks the problem is solved. It's not solved. One only needs to look to, for example, Washington, D.C., our nation's capital, to see one of an epidemic that is, frankly, out of control. If you are African American in the United States, of course, you have at least a 9-fold increased risk of contracting HIV. If you're Hispanic, it's 3-fold compared to Caucasians. So this is an epidemic that is affecting people of color, and it's one that we need to take. It's not gone. It's not over. I think I'll just close by making one other comment that now one of the great challenges for basic science in the HIV epidemic is the challenge of the recognition that individuals, despite almost perfect antiretroviral therapy, they're dying 10 to 20 years before cohorts that are not infected with HIV. So there is an accelerated aging phenomenon that we do not understand. Could it reflect low-level inflammation? Could it reflect the effects of reverse transcriptase inhibitors that might be inhibiting enzymes which regulate the length of our chromosomes, which shorten as we age? There's all kinds of possibilities for what is causing this accelerated aging. But it is a significant problem that individuals with HIV infection are dying 10 to 20 years earlier. They're not dying of AIDS deaths. They're dying of diseases of the elderly, common heart disease, liver, dementia, cancer. This will be, and this is of course affecting all segments of the HIV-infected population. So we are, that's a new frontier for basic science. It certainly is relevant and will impact the disparities in healthcare delivery that punctuate the HIV epidemic here in the United States. But enough of the welcome. I hope that you enjoy the conference today. I'm certainly looking forward to it.
So thank you both, and we'll now move right into the first couple of presentations on the overview of the epidemic from the various different perspectives. And Cynthia Gomez will come up and give the first presentation. She's the founder and director of the Health Equity Institute at the Santa Fe State for the past 6 years, and previous to that, she was a co-director of the CAPS at UCSF. And her research is dedicated to linking science to practice. Cynthia.
Good morning. Actually, I think we've probably confused.
voted
I'm not
yes.
Cynthia, because we had Valerie, I think, coming up first. So.
Okay, that's okay, we'll switch back. That's okay, we'll just switch.
Or she can start. We can swap. Let's swap, Valerie. Why don't you come on up? We'll start with Valerie first, as previously planned.
Okay, well, good thing Cynthia is the same size as I am, so we don't have to make any adjustments. I even have heels on. Hello, my name is Valerie Eckert, and I work for the Office of AIDS, Department of Public Health, Center for Infectious Diseases, I previously worked in HIV prevention branch on prevention data, which is counseling and testing data and health education risk reduction data. And then just recently went upstairs to work more on the surveillance data so that we could, because our office is sort of redoubling and focusing on sort of triangulating all of our data systems to really get at a lot of the things that we're going to talk about today. And so I prepared my presentation. I was coming to this conference anyway, regardless, and and then I was informed that maybe they might need something from me, a little bit of data and some input, so I was happy to do that. Because this is a really important concept to me, the concept of disparities and then overarching social determinants and really our limitations and on how to measure and really kind of using our creativity in that. So my talk is a little bit on the epidemic in the Bay Area, but it actually really goes into how we're measuring how the state, like what can I give you from my perspective that you might not get from someone else in this room, and that's some of what we have at the state level and data collection systems there. So I apologize if it might jump around a little bit, but it's sort of showing you how we can sort of triangulate what we have. So bear with me. Am I going to do the slides myself? Where is it? Oh, there it is. Okay. So this is, I think we probably all get a little bit, like we hear factors, cofactors, drivers, social determinants, and it all kind of gets sort of unwieldy. I think in this presentation or the next one, maybe I think they're going to define it a little better. But I'm going to just talk about, for my purposes at the state level, what we can measure easily and what we do measure, and then what we becomes a little trickier, but we still are trying to measure, and then what we really just are having trouble with, which is where we need community folks and academicians to sort of collaborate with on these. So in demographics, we have basic race, ethnicity, gender, and for some reason I left out age, but we have that as well. This is how we typically see our cases presented. We have we collect data on residents of diagnosis and at current residents, as current as we can get from the recent lab tests. So we can get that information quite easily. For transmission-related risks, we have risk groups, and we all know the classic risk groups, MSM, MSM-IDU, heterosexual, high-risk heterosexual. We kind of know those, and we typically present them in a hierarchical way. Then we can look at STD prevalence through our colleagues at the STD control branch. We can look at co-infection from specific studies. STD has been known to be either a cofactor or certainly an indicator of unsafe sex, so a proxy for unsafe sex. Then there's this concept of infectiousness that leads to transmission that we can study. There's community viral load studies out there that San Francisco has done some amazing job on. The state is a little bit behind in that respect because we're kind of dealing with a bigger sort of, pie of jurisdictions. But the way we can look at it that I'm going to show you here is like looking at just late testers. Did you test at the same time? When someone tests positive, did they test for HIV and AIDS simultaneously, or did they progress to AIDS within a year of their HIV diagnosis? And then we can look at non-adherence. So all this leads to infectiousness of someone, which eventually leads to transmission risks. And then of course, that kind of leads to social networks, and then there's bigger concepts of social determinants that we're going to talk about here. And then, of course, there's the other concept of social networks. Well, can we measure social networks? Kind of. I mean, at the state level, we can kind of measure that by doing, by mapping, because we really only have residents of diagnosis, and we have current residents, and we have other things like facilities that they are visiting. And so in those kind of ways, we can maybe triangulate, but that's still, you know, that's the best we have. So, and then other measures are, that we know that are bigger and become more and more difficult to look at, are poverty, living environment, which means we have to go toward, you know, again, we have residents of diagnosis. Sometimes it tells us whether or not they're in a correctional facility. Sometimes it tells us whether or not they're homeless, but often it doesn't. Our data aren't really always clean, but we've taken some steps toward that I'll get into later. Or we can use poverty, we can just overlay with what we have, and this is a really big thing now that we're doing, is overlaying our data, trying to, in all of the public health, using GIS mapping and other spatial analyses to really, really get to the heart of sort of the living environment. And then there's access to services that we can measure, quality of care we can measure, incarceration I already spoke about briefly, and then and homelessness. So these are all measures that sort of, this is by no means an exhaustive list, but this is sort of how the state is sort of trying to understand why, when we have two individuals who are participating in the same exact risks, why one has, you know, a 6-10-fold risk of contracting or transmitting HIV. So, oops. I'm talking fast because I have a lot of slides and I don't have much time. I apologize if I'm too mumbly. This is just a picture of California, really a picture of California, and on the right is not prevalence, but new cases diagnosed in 2010, and then by county. The left is the diagnosis rate. And you can see that nobody's surprised that the Bay Area, Southern California, is where the cases are. And then by rate, you can see that sort of the county level, the central level, central area kind of starts getting highlighted a little bit. But we're not talking about any of that. We're talking about the Bay Area. So these are the counties that we're looking at, that I was told we're looking at: San Francisco, Alameda, Santa Clara, Contra Costa, San Mateo, Solano, and Marin. I hope those were the correct counties. And this is actually a promising slide, right? This is a trend. This is from 2000 to 2010, and this is the number of new diagnoses across those times of new HIV diagnoses. And HIV, a new diagnosis means HIV or AIDS, regardless of status. They were newly diagnosed during that year. Cases are going down. I have to put in a caveat that our data are all those estimates. I think everyone here knows that. Our data are always estimates. And we recently had conversion, or 2006 we had conversion to name-based reporting, and so we had to re-ascertain cases, and so just that's a limitation of our data. Excuse me. So I just need to throw that out there. It should be on the slide, but I don't want to bog us down. But so always look at these as estimates. But I think it's really well established that San Francisco cases have been going down for a while now, and I know the San Francisco folks in the room who can attest to that. So, but the other, in the other counties look like they're staying relatively stable. But I mean, obviously, further analyses will show, will highlight these. But the top slide is by race, ethnicity. The bottom is by exposure group, and you can see that in the top, the white population. This is combined, all the counties combined. So the white population in these counties combined is declining pretty steadily and pretty dramatically, whereas the other race ethnicities aren't. There is still a slight decline among blacks, African American black folk in the Bay Area, and all else seem to be holding steady. So. In the bottom, you see MSM population is decreasing, probably not quite pretty steadily, but you know, if you look at other cases, it's it's declining rapidly, but it's because there's a larger population, so it looks like it's more dramatic than the other populations. But there still is a decline overall, and I think that's a point to make. A bigger point to make also is when you look at the 2010, you can see that a snapshot of the data in 2010 shows you that the picture of HIV is starting to look different. Right? It's starting to look a little more minority. It's starting to look, in the next slide you can see, this is age group. It's starting to look a little more young. So this is age group at the top. Really the 20 to, the 30 to 40, 30 to 50-year-old age groups have a dramatic decline. Other age groups are staying relatively stable. But what we see here that was a little bit disturbing is that the one increase in trend that I've seen in any of these slides is the 20 to 29-year-old age group. So, and that's in the green there. And that's among all populations. I'm sorry, I can hear myself breathe. Okay. In the slide below, I just separated MSM and MSM-IDU. And it's the same thing. I apologize, I should have coordinated, but on the bottom slide, the 20 to 29-year-old trend is in red. But there's still an increasing trend when you separate just MSM-IDU. So there's an increase among that 20 to 29-year-old age group. And some of you may be finding that in your own studies or in your own literature and so on. So this is a snapshot. So this is for just 2010, the year 2010 only, and the data set was frozen February 2012, in case anyone's wondering. So the numbers may be a little bit different if you're from one of these counties and my number is different than yours. It could be because I froze it a little later, so some cases may have been reported in, and then sometimes you have different. I allowed cases when they didn't have some of the variables included. So just so people know that's why you may have a few different numbers. But relatively, it's the same. You have the counties are, Marin all the way to San Francisco. Marin, Solano have the lowest number of cases in 2010. San Francisco the most. I don't think we're surprised by that. And then the rate of diagnosis per 100,000 population sort of gives you the perspective there. And it plays out somewhat similarly. You may have the question about Marin, if it includes correctional populations. Yes, it does. And then you might, Solano as well, I believe. So all correctional populations are included in these estimates. So when you look at the rate, though, this is where the disparity shows up for race ethnicity. So you have the population, again, across all the counties that we're looking at, the Bay Area counties. By far, the greatest number of cases are among whites. Newly diagnosed 2010. Next is Latino and Black, similar, and then Asian Pacific Islander. I recognize the need to split those up, but I did not do that here. I apologize, but I think they're very distinct populations, and I will do that in the future. But when you look below and you look at the disparity, this is just, it's a simplistic slide. I know you all seen this before, but it really does highlight that, Black African American in the Bay Area have threefold chance. They're in the Bay Area. This is actually not nearly a disparity as it is in the South and in the Northeast, and I'll show you that in a minute. But it's still here, and it still looms large, and I think it's a really, really, really critical thing that we address. And I know you all know that here too. I don't think I'm saying anything you haven't said already. So. And I just want to also point out that an American Indian, Native American, it's such a small number that I probably should have just left that one out. But it is a population that's tricky to address. But I feel like that we really definitely need to focus on and do a little more exploration with. So I think that because they're not, it's harder to measure in other parts of the state, but California, we actually do have the ability to do that. So, okay. This is where I just tried to compare the U.S., California, and the Bay Area, just to give you a sense of sort of where we are in the, how we relate. And this is at 100%. the distribution of cases for 2010 is what? So for the first one, it's U.S. It's 46 states, I think, and 5 jurisdictions. So that's who's counted in the U.S. figures, and they're just right off bat, the difference is that the U.S. has around 20% female. We have around 10. So it's like their distribution is a little skewed that way. And then in race ethnicity, it's a little messier. I have the numbers above our Bay Area just so that just to show you that that's the one we're really interested in. But for race ethnicity, you can see that for it's really quite dramatic, the difference between black, white, and Hispanic, and then actually even Asian Pacific Islander. But in the U.S. figures, there are far more, as a percentage, a proportion of all the cases, far more black African Americans, and far fewer Latinos. And in California, it is the opposite. There are far more Latinos than black African Americans. And in the Bay Area, you have far more white than both California and the U.S. So we have a little bit of a different demographic here. And for the most part, we mirror the state, but there's a little bit of demographic in terms of our population being more white. And then if you look at the rates, the rate per 100,000 is higher for whites than in the Bay Area than it is for both California and the U.S. This is, a slide of the cofactors. We know, I don't want to, this is just snippets of cofactors because they don't have much time. But this is, we all know that STDs are cofactors, drivers, but they're also indicators of proxies for unsafe sex. So this is from our friend's website, the STD Control Branch, and these are just the syphilis and gonorrhea in particular, and the cases per 100,000, the rate of incident syphilis and gonorrhea for 2010 for these counties, and they just lay out similar to what we find for HIV. There was also a study done in our office with Michael Samuel and Nicole Olson, and they looked at prevalent HIV/AIDS cases and incident STD cases. And what they found was that among those living with HIV, the highest incident STD cases were among males aged 20 to 29 years old and living in San Francisco. So, and then the highest incident cases were among blacks, and particularly black MSM, but that was across the state. And then also, interestingly to me, was that incident syphilis cases were highest among Asian and Hispanic race ethnicities. So, and I don't know, I think there's some folks, STD folks in the room that might be able to speak to that. So I'm skipping now into, again, because of limitations, I have more that I can't present, I have more data, but how do we as a state measure some of these things, some of what we're trying to get at here? We want to measure, transmission risk, the concept I mentioned, late testing, like a higher viral load. And so how do we understand, aside from this community viral load, how do we look at it from our state data? Well, we can look at late testing, and that's folks who are diagnosed simultaneously with HIV and AIDS, or who progress to AIDS within a year. And then that's also, what does that do also? Well, that tells us what the access to care is, too. If they're late testing later, that means that they are not accessing care at the right, early enough. So age of diagnosis, late testers from 13 to 19 to all the way up to 50 plus, you can see that makes sense, that the older populations are more likely to test late. In the bottom, you can see that Latino and Asian Pacific Islanders are more likely to test late. And the state average is in the middle there, 36.1%. So, 40% or 42% of the populations of Latinos and Asian Pacific Islanders are testing late. So that means they have AIDS at the same time or within a year of first testing HIV positive. So that's a really important thing that we need to actually work with these populations to get them into testing and access to care. And again, these are all ways that we can look at our own data systems, and this is how you can access them as well. So the areas of focus that we're looking at is using our surveillance data better, in a better way, to measure these types of things. You know, and the National HIV/AIDS Strategy objectives are some of those, and I think we're going to talk about that in a couple of days. Then we need, you know, in order to do that, we're increasing our lab case reporting abilities, which is going to kind of beef our ability up, so that we can really get a bead on what's happening real time. And then using these data to sort of target populations and address disparities. And then the next thing is geographic presentation of data. So the linkage to care, this is an example of our data. One of our goals is to address viral load, you know, to increase viral load suppression among MSM, bisexual, and blacks and Latinos. But we're looking at our data here. This is statewide data, not just localized data. You can see that among black population, the viral load is significantly different than all others. So they are not, this percent suppression. So 70% are suppressed versus 80% in the rest of the populations. And that's, of course, of those who have a viral load test. So these are ways we can measure in the community, like, you know, whose viral loads are suppressed, what populations, and then we can use mapping, et cetera, to sort of understand where those populations are. This is ADAP. Looking here, you can see this is the insurance data collection, the insurance program for AIDS case. We all know what ADAP is probably. And then you can see here 22% of African Americans have less than 200 viral load, and that's compared with 16% for whites. So and then 27%, so 28% have, a CD4 count of less than 200. Not good, so that's a disparity that we want to address. How do we want to address that? We are trying to enroll folks in ADAP earlier so that they have a higher viral load, and looks like we were successful in doing that. So we are increasing, so the folks, the percentage of folks who have a viral load, a CD4 higher than 200. So this is the state, so this is how we can measure through state systems. The geocoding project, what we've done is map, so this is our ability to map. We've used the diagnosis address and the current address. We've actually mapped that so that our geocoder is a project, and the geocoder actually went in and looked at specific addresses and Googled it to see if they were either homeless or they were in a residential shelter, or if they were, if it was a street corner, or where it was, so that we could actually get a really clear picture of homelessness and networks and incarceration. So those are all ways that we can map at the state level, and it's ways that we can actually help you. You can ask us for those data, and we can provide those for you. And we have a lot of other data sources at the state that we can also use to triangulate our data. Let's see, I think that's it. And then, overall, we have what's called a health disparities framework. It's a framework that we put together to sort of like, make a commitment to use all of our data sources at hand to measure what we can with our limitations, and then overlay those with whatever else we can get. Surveys from outside, studies from outside, census data, American Community Survey, which is probably on the cutting block. So this is how this is really what we've done, and we put together a document, and it's a living document. And then we have profiles, we have minority AIDS initiatives, other insurance programs that are working toward certainly addressing those targeted populations and minorities, underrepresented minorities. And then this is my information. I love this. This highlights the need to have the right location and use GIS mapping and targeted services. I'm done. I know that was fast. I apologize. And does anybody have any questions? Are we doing questions now? Okay.
Good morning. How's everybody doing? Great to see some old friends. It's been a while. Nice to have a great combination of colleagues here. I'm going to be talking to you a little bit about framework and thinking about HIV as a model. Will we lead the way in the Bay Area towards health equity in San Francisco? Now, many of you, as was mentioned earlier, you know I was at UCSF for nearly 15 years, and now I'm at San Francisco State University focusing on health equity. And it's a mindset. You really have to change how you think, and I'm hoping that's part of the discussion that we have today. I'm a psychologist by training. I've been trained to think at the individual level. I've been in public health. I've been trained to think at the individual or population level. But now we're in a different phase of an epidemic, which is we're no longer trying to stop, I mean, we are trying to stop it, but not in the same way that we were in the beginning. So just want to really work with you to have this mind shift together. I want to start by thanking Margarita, who also we sat down and had some conversation about this together conceptually. And I also want to acknowledge that some of the content also belongs to Tony Iton when he was at Alameda County and was talking about some of how we look at disparities and inequities. I wanted to mention also to warn her that we have this dialogue. We're a transdisciplinary institute with basic scientists through behavioral scientists, and often the question from the basic science is, well, where does disparity land within the basic sciences? And so we always joke about that cells have a context too. And so something to think about as we move forward. Okay. So many of you in this room remember this moment in history. For some, it was about them, Paul. But what this starts right away is telling us that we are dealing with a socially based disease. Right? So the first thing it tells us is that it's about homosexuals. And you may remember that we went from that to the 4-H club. Homosexuals, hemophiliacs, Haitians, and hookers. No, and heroin. Hookers substituted for hemophiliacs later on. So it was, quote, the bad people that were becoming infected with this new disease. So from the start, we started with a stigmatized and socially based disease. Forget about how you got it, what the situation was. We already had the 4-H before we even knew how it was transmitted. It is only 30 years later that we can retrospectively say, oh my gosh, what damage did we do early on with that concept, right? And it's still here today. It's still driving people's perception today. What we do know is we're talking about intersections today. We're talking about the intersections of class, of race and ethnicity, of gender, of sexual orientation. Lots of intersections. And it is that sort of shift that was mentioned earlier, that we started with a relatively middle class, predominantly white, gay population, and we have seen movement towards African American, poor men and women. And again, this is one of the most natural courses of health disparities that we might see in our lifetime, and need to understand what that's about. So the Bay Area was a leader then and can be a leader now. My gosh, the model was named after us, the San Francisco model, which meant bringing together of community of science, mobilization, the advocacy that came from people living with HIV and those impacted by HIV. The East Bay, hub for social justice. Oakland, state of emergency, the first location in the United States that declares a state of emergency to underscore the disproportionate burden on African Americans of HIV. Very progressive gay and transgender politics in the Bay Area. And then the amazing biomedical and behavioral innovation coming out of this region. Certainly, that combination means we can crack this next phase of really trying to understand social determinants of HIV and how we intervene with those. The global context has given us this already. In the global context, seeking global health equity, we're trying to be very clear that health will drive the world. If we do not have a healthy globe, both environmentally and its people, we have no future. But when we talk about health equity, we're not talking about health care. I want to be really clear about that. People kind of get confused and think that, oh, well, we're just talking about access, right? No, we're not even talking about health care. I mean, we can talk about health care, but it's a sliver of what we're talking about. On the global picture, real efforts were made with the Millennium Development Goals. And I think what you see right there is a recognition that even before we go into sort of the medical model of the three in yellow in the middle, really to even begin to impact those, we have to address poverty and hunger, the extreme poverty and hunger in the globe. We have to achieve universal education. We have to promote gender equality. And again, addressing these other specific issues are critical, but those first three have a lot to say about preventing the following three. And of course, ensuring the environmental sustainability and creating a global partnership. So what do we mean by health inequities? So let's just get our terminologies together because we all might have different ways of thinking about it. So I'm just putting up a couple of definitions, starting with the inequity part. So health inequities are differences in health status and mortality across populations that are systemic, avoidable, unfair, and unjust. Okay, so we're not talking just about who's getting it. You know, it's not that, oh, there's this disparity, this group gets it, this group doesn't. But it's when there are inequities that are unjust and avoidable. And so that's really something that is the first mind shift I really want to encourage you to take, is to think for a moment about how do we avoid the disparities from that definition. And so then looking at health equity is something we're trying to achieve, right? It's a special effort to improve the health of those who are experiencing these disadvantages, these social or economic disadvantages. And we're really oriented essentially to increasing everyone's health to the best possible health they can have. Okay, so really the highest level of health possible for all groups. So it means special efforts for certain groups if there has been an unjust disparity. Okay. One of the other ways to think about it, and the World Health Organization and others have talked about this in thinking about social determinants of health, is why treat the patient if we do not treat what's making them sick? Why bother? Why do this? So for us, it's like, why do we continue to do the same individual level intervention if we're not going to change the context under which risk is actually occurring? So in 1979, our public health model brought its first way of trying to decide how the 10 leading causes of death, what was contributing to them. And again, this is still our public health model today in many ways. The distributions might be argued a little bit, but I think what you see is that we think half of the reason people get what they get is because of their behavior. We attribute, and this was in 1979, 20% to environment. And here they actually meant physical environment, toxins, environmental health type things. Human biology and inadequate health care, even then, was only a 10% sliver. Okay? Now, this continues to be our public health model. In David Satcher's time, tried to expand more of the social determinants lens by thinking then about the social environment and the physical environment as two separate entities affecting the individual and, again, their behavior and their biology. And on the outside was the access to health care, policies and interventions that can impact this model. Now, what do we mean by physical environment, social environment? Well, essentially in the social environment, we're talking about this aggregate of social, economic, and cultural institutions, the norms, the patterns, beliefs that somebody has throughout their lifetime. Certainly, for me as a Latina woman, I grew up with many different gender expectation and norms. I grew up with society's view that I should have been pregnant when I was a teenager, dropped out of school, maybe crossed the border illegally, certainly not get a degree from Harvard. So these are norms and expectations that are embedded in society already about us throughout our life course. And that's my social environment, that's your social environment. We each have to interact with that social environment. The physical environment, of course, is the structures that are both our natural and our built environments, our institutions that influence the health of individuals and communities. So we can call these societal determinants, referring to both the social and physical. And so, for example, if we're living in this neighborhood, we are going to have a certain experience in life if this is our environment that we live in. And, you know, last year, a couple years ago now, I did a photo voice project with residents at Bayview Hunters Point and asked them to take pictures about their neighborhood and tell me how they represented the neighborhood, both in a negative and in a positive way. And we had many pictures like this that talked about feeling like they were in a community that had been abandoned and that had not been maintained, and therefore feeling sad and feeling disenfranchised. And you are going to have these impacts. I mean, you know, we have studies that even show, you know, the comparison of, and again, a personal experience. I feel much better when I'm driving on 280 from my my peninsula location where I live versus on 101. I mean, those are two different environmentally different experiences. I can have the beauty of the mountains on 280, or I can have the horrendous industrial look of 101. It's a different spiritual experience while I'm driving that impacts me, impacts my mental health. Okay? If I'm living in this kind of a neighborhood, I have a really different experience. You know, I have parks to ride my bike in, take a nice walk, feel safe. I feel part of something that is taken care of, that is valued, that affects me as an individual. And if we then just look in generally looking at neighborhood poverty group, and I'm sorry this got a little bit fuzzy here, but there are differences in then how by race and ethnicity we might handle living in certain environments. And this is an interesting slide that people have had different interpretations, but if you're living in a high poverty neighborhood area, your life expectancy, specifically for African American and whites, drops substantially. We don't see the same pattern among Asian and Latino populations. And there are a lot of theories around that, these being populations that are more recent immigrant populations. They're used to crowding, they're used to transitional environmental housing, if you will. They have multiple generations with them that are providing different social support, et cetera, a lot of different things. But clearly, for blacks and whites to live in poor neighborhoods is bad for your health. Okay? Here are some examples just in the Bay Area, and again, I thank Tony Eiten for these. Bayview Hunters Point has 14 years less in life expectancy compared with Russian Hill within San Francisco. This is the same city, two different neighborhoods, extremely different. 14 years difference in life expectancy. Bay Point versus Orinda, Contra Costa. West Oakland versus the Oakland Hills, 14 years. Dramatic. I mean, we're not even talking about, 20 miles distance. We're talking about a few miles distance. This is a dramatic, sort of way of thinking about how can this be? And it has to do with our health is impacted by these other environmental pieces. So in the Bay Area, for every $12,500 in household income buys you 1 year of life expectancy. So those of us who are in public health jobs, we've got to find some more income if we want to live longer. Okay, so what's the point of all this is to tell you, okay, so the institutional powers impact our health, the built environment, how the land is used, right? I mean, this is something that we're finally talking about. We build new housing, we have to build it in a way that provides space for exercise and walking, where you're going to feel better. Our Hope SF is a really important thing going on right now in San Francisco, which is to tear down the most, the public housing units that are just falling apart, and reconstructing them to be mixed income housing with more resources, well thought out environmentally, using the resources and the assets of the community to build its infrastructure, not just build a big building and put people in it. Our natural environment, we're really fortunate in the Bay Area. We have this beautiful natural environment that we need to pay attention to, I mean, I'm really happy the Warriors are coming, but oh my God, they're going to build a stadium on the pier? We're going to have all that traffic? These are things that will affect us. And of course, our social environment. So what influences economic investment, employment? These are the institutional places where we'll start to see some differences. So here's a framework that the Bay Area, Bay Area, it's all of the Bay Area public health directors, right, have formed the Bay Area Regional Health Inequities Initiative. And this was, I found, an extremely helpful framework, which is to think about our medical model and the public health model to be where we have focused. And in HIV, it was appropriate when we started to focus here. What was going on? What was happening in terms of HIV being the disease? What was going on? We were looking at basic science, was looking at genetics. We were looking then, of course, at the behaviors. Remember that 1979 slide I showed you? This is where it stops, is we find out what the behavior is, we change the behavior so that this doesn't happen, and we increase life expectancy. And we make sure there's healthcare access, and we make sure that there's individual health knowledge. But this is where we generally stop, right? We've done our job, we figured out how it's transmitted, we know what behavior people have to change, and and we were sure we were over. I mean, I moved to San Francisco to stop the epidemic, and I thought that we were going to do it in a short period of time. And I didn't think I'd be up here, 30 years later, talking about how do we stop the epidemic. And so what the emphasis now here is to think about the socio-ecological contribution. So these behaviors are not happening out of context. Even when we do risk assessments, when did you have sex, and how many partners, and did you use a condom? Do we ever ask them, like, what was the situation you were in at that moment? Or what is your situation, right? We're getting better at that, but really our focus is usually strictly on changing the behavior. So what about the neighborhood conditions, the environmental, social ones we just talked about? What about racial segregation? Again, in Oakland, where we see the pockets of the highest rates of infection of HIV are the same census tracts of the highest poverty rates, and they're the same census tracts that did not allow Black and Latinos to move out of those neighborhoods, because in the other neighborhoods, we weren't allowed to buy property. Those laws are actually still in the books. We were not allowed to buy property in the nicer neighborhoods. And it kept people of color in certain environments, on certain sides of the freeway, certain side of the railroad track. You all know how this works. But it was structural. It was structural. It was not the individual. It had nothing to do with the individual. It was structural. And again, the institutional power that then enhances some of those structural inequalities. And of course, the social inequities that I started with, the assumptions of the intersections of race and class and gender, immigration status, et cetera, et cetera, et cetera. So what do we mean then? We mean these are the health disparities, and this is what we have talked about, but we really need to intervene with the health inequities if we are going to ever really achieve health equity in any field that we look at. But certainly HIV is right there. So I want to just keep you with that, to remember that part of what we're trying to talk about is how do we address the inequities while we continue to try to prevent the disparities. So it's not one over the other one. So the option for intervention is at all levels, and including, so we focused on individuals, some on community, but organizations. We have to change how our organizations work. Our infrastructure, even in the Bay Area, as rich as we are, if you will, we have our local community-based organizations, our local health departments, with horrendous infrastructure, horrendous ability to deal with some of these issues. And, also dealing with science. We have to change our methodology. We can't use the same methods all the time. We have to challenge that. These are the different things we could do at the individual level. We need to think about community assets. How do we actually help our communities build the right infrastructure, educate, train, create economic development? And so there's a paradigm shift that we have started in the Bay Area, which is our right to health, that activism that we've seen here to demand. But it's challenging for a lot of different reasons. So we have to play a role in all of these areas. We have to get community engaged research as part of that. We have to come together as scientists and as providers. We have to impact at all these different levels, policy and that transdisciplinary approach, that broader lens, incorporating the cultural experience. And we're all working in the trenches, and it's hard work. So I will leave you with, let's return to activism in terms of dealing with social inequities. How do we actually address those in the way that we addressed HIV in the beginning? How do we understand the privilege that some may have? You can be on the people walker and just take you to privilege. If you're not of upper class, maybe you have to jog. If you're a man of color, you actually have a few boulders that might hit you, and it's going to take you longer. If you're a woman of color, oh my gosh, you really have to climb those boulders and avoid those pitfalls. So if you even get anywhere to the same location, we have to understand what is the resilience of this woman. My God, how did she get there? She overcame that much more than the guy on the people mover. We have to understand that in our own work and creating change that matters. And I know that you guys can do it. I've been worked with many of you for many years. So let's lead the way. Thank you.
So thank you both, Cynthia for the presentation and also for the previous one. I think it was an incredible overview, and I bet not many of you actually knew all of the information that the Department of Public Health at the state level actually has, and you can think about ways that that can influence your research. We'll move right on to a panel discussion which will further discuss the disparities and health inequities, you know, within the Bay Area. And I would call on the moderators. We have Jim Sorensen and Shirley Manly-Lampkin to come up, as well as the panelists. I will let you introduce yourselves. And the idea here is nobody will actually have a presentation, but it's really a discussion that will continue along the lines of what we have just heard. So if all the panelists, please, could come up. We have Ifeoma Udoh, we have Hyman Scott, we have Brian Grossman, we have Fisher Raymond, and Ben Cabangun. You could all please come up.
Well, good morning, everyone. This is a panel discussion, and we are also the last thing between you and your morning coffee break. So we will do our best to then move ahead and be done at 10:20 today. My name is Jim Sorensen. I'm on the faculty at University of California, San Francisco, specializing in mental health and HIV and drug use issues. Maybe what I'll ask is that our panelists introduce each other. My co-facilitator first, and we'll go right on down the line. And then we'll give people a chance to say a few words to you afterwards, or, you know, about what it is you have to say, you know, what your main point is, because I know it's everybody submitted to us a paper they were interested in. So we'll give you, if you could, first we'll do introductions, and then we'll introduce the panelists and give them a chance to have their say. And after that, we'll then have, I encourage you to be taking notes and thinking about this and raising questions. We have two microphones for the audience. One is 1 and one is 2. And we hope to reserve at least 10 minutes of our time for that. So Jim Sorensen is here.
I'm Shirley Manly-Lampkin, Assistant Dean of Academic Services at UCSF School of Nursing. I'm also a member of Allen Temple Baptist Church, where we have an HIV/AIDS program, and was part of Alameda County's Ryan White HIV program.
Good morning. My name is Ifeoma Udoh. I'm with the Pangea Global AIDS Foundation. We are a nonprofit organization based now in Oakland, California. Many of you may know that we were previously associated with the San Francisco AIDS Foundation. We moved to Oakland in December of 2010.
Good morning. I'm Damon Francis with the East Bay AIDS Center, and just really happy to be here. Thanks.
I'm Hyman Scott. I'm one of the infectious disease fellows and also fellow at the Center for AIDS Prevention Studies.
Good morning. I'm Henry Raymond. I'm the Director of Behavioral Surveillance at the HIV Epidemiology section at the Department of Public Health.
Good morning. My name is Ben Cabangun with the Asian and Pacific Islander Wellness Center here in San Francisco, and I'm happy to be here as well.
Great. We had a very exciting and enlightening, I think, plenary just ahead of us. And I want to ask maybe Ms. Udoh first from the Pangea Global AIDS Foundation, if you have anything you'd like to emphasize in response to being here.
Well, thank you for asking us to be here, number one, and it's nice to see so many familiar faces. I think one of the things that strikes me in particular about Dr. Gomez's presentation is the thinking through the connection between the disparities that happen here in the United States and the framework that happen at the global level. And of course, with the work that we do at Pangea Global AIDS Foundation, where we're really committed to research and equity and monitoring and evaluation with global programs, we've also really been rooted in establishing our work here in the Bay Area, in particular with the project based in Oakland, looking at the concept of late testing amongst African Americans and Latinos, and we'll talk about that a little bit tomorrow during the poster presentation. But one of the things that really struck me about Dr. Gomez's comments with regards to the Millennium framework that was set and established at the global level is the gap around how that did not necessarily happen here in the United States at the same time. As many of you know, we all have just recently moved forward with respect to policy in the United States with having a national AIDS strategy, whereas at the global level, countries, in order to receive funding from programs like UNAIDS or Global Fund, had to have the 3-1s approach in place: monitoring and evaluation strategy, a national AIDS strategy, and a national AIDS coordinating council that monitored what was happening with the funds that were coming in from global donors. And so the fact that we're just moving towards that direction with respect to the policies here in the United States, I think is quite telling of the gap in terms of addressing health disparities and health inequities. And so I really appreciate that framing of it, and hopefully as a part of this conversation during these next few days, we can talk about how we can really move in the direction of addressing health disparities from that rights-based framework.
Great. Damon Francis, maybe if you wouldn't mind saying a bit about where you're from also again, because I see that you weren't on the, you were left off on this version of the program. Sure. But he's really here.
I'm a physician at East Bay AIDS Center. I also work in the public health department as the medical director of the Urban Male Health Initiative in Alameda County. And I think the concept that I really like to emphasize is that innovation that's sort of unconscious of disparities is really likely to exacerbate disparities. And we really have to develop ways to innovate that are conscious of disparities at the time of innovation. Because when we develop a new technology or we develop a new innovation and we layer it on top of that framework that Dr. Gomez put up, you're really lifting up the people who are sort of already doing better, and you're still having a hard time reaching the ones who are doing worse. So I think, you know, one of the contexts I'd like to bring to the scientists, you know, that affects me in my daily life is how do we innovate in a way that shrinks disparities, and how do we consciously do that?
Great, thank you. And then I'm looking down. Is Brian? Are you next? I'm sorry, I just can't quite see.
Hyman.
Pardon me? Oh, Hyman Scott. Okay, great. Hyman Scott is from UCSF and the Center for AIDS Prevention Studies.
So one of the things that I think was I was struck by Dr. Gomez's talk was the social determinants of health are such an important part.
Could I ask you to speak into the microphone a little more?
Are such an important part of, you know, these inequities and disparities that we've seen that have been present since, you know, the last 10, 15 years or more. And we have been making all these technological advancements, as Damon sort of mentioned, but these disparities have only widened. And I think addressing the proximal, that's the one of the things I was struck by the most by, was addressing the proximal causes of these health inequities is really the only way that we're going to be able to really address the health disparities that have just been expanding in the last, you know, 10 to 15 years.
Okay. And Mr. Fisher, as an educator, how do you begin to look at the framework as you reviewed and listened to the presentation from Ms. Gomez this morning, where she showed the slide that 50% of what we are currently doing in our educational system when we're educating health providers or nurses?
I'm not an educator.
Okay, but that's okay. You can still maybe think about it for those of us who are educators. How do we begin to address the curriculum? In her slide, she showed that 50% of what we're doing is currently around the medical. How do we treat the individual? But when you look at the social and behavioral context that she talked about 10%, if I reviewed her slide correctly, was looking at those social determinants. How would you frame that for us?
Well, I think it's pretty clear, especially among MSM, that disparities are not fueled by individual level behaviors where risk levels across races are very similar. And I think it really does encourage us as scientists, and I guess to trickle down to education, I'm not quite sure at what level you meant, to start exploring alternate, you know, approaches and alternate ways of looking at how environments, how social networks, how sexual networks influence people's, not necessarily risk-taking, because as I said, risk-taking is pretty similar, particularly among MSM. But you can also look at environmental factors where, for example, individual income levels doesn't necessarily predict engaging in unprotected sex with serodiscordant partners, but the density of HIV positive people in a certain environment dictates that.
And Ben, how do you think we engage the community to become more involved in the HIV/AIDS arena?
Well, one, I was really inspired by Dr. Gomez's talk. I'm a fan of her work. But I think it really spoke to me and my colleagues at API Wellness Center in particular, because I think that's currently what we're trying to address right now, is how to better engage our communities to access HIV testing in particular at API Wellness Center. And I think one of the main things that I wanted to bring up is that our work and our outcomes really emphasize right now that there's a world beyond kind of our thin understanding of race. I think a lot of us have a very thin understanding of what that means, and a thin understanding of race and HIV incidence as an outcome of race. And so I think it's an opportunity for us as researchers and also direct service providers to kind of look beyond our superficial understanding of race and racial disparities, and to confront culturally specific HIV risk factors in that social production of HIV in our diverse communities. For example, with us at API Wellness Center, looking at social context, at income, education, and nativity in particular.
Great. Thank you. I want to, in preparation for people in the audience, I want to mention this is your chance now to come up to the microphones. The intent, I think, of the conference has been to have a discussion back and forth, and the intent of these panels is also to have that. So this is your chance, and I encourage people to come up to the microphones to have your say. That's, you know, you have your say, but the price is you have to stand up for it. So please, I want to invite people to come up. But meanwhile, I just want to ask for the panelists if you have anything in particular that you would like to emphasize as we continue.
Sure. I actually wanted to follow Hyman with this statement. I think that we need to be very careful about measuring disparities. I think that things can change quickly, and that the disparity moves in a different direction. I hope everyone has a chance to look at our poster back there during the break, because I think it may challenge the paradigms. And so what may historically be the disparity may change, and then it requires us to take a step back and be more subtle about how we discuss disparities, how we prioritize the areas and policies we need to change.
And I got a chance to see Dr. Raymond, your work a couple weeks ago, and I definitely agree with kind of the results that your work is showing. Definitely inspired us to reframe our thinking of disparities and to look at other areas. Definitely.
So when you look at the a slide again, going back to Mrs. Gomez's slide around the upstream and the downstream of providing health care, or even in looking at how over 30 years the face of HIV/AIDS have changed, how do we address that when we're looking at these large institutions? Or in her video, I mean, not in her video, but in her slide, she showed where in the flatlands of Oakland or in the Bayview, now where those HIV/AIDS rates were not as high 30 years ago, but now they're high, and there's no services, or people feel disengaged. And any of the panelists can address that.
You want to jump in? I was going to. Okay. Well, I think one thing in particular that kind of strikes me, being from Oakland and working in Oakland, and one thing that in particular strikes me about our infrastructure in Oakland and our ability at not just the community-based level, but also at our public health level to really utilize the data that either exist or to understand how to access data to better tell the story of what's happening. In particular, one of the things I think is a challenge for us is thinking through the need for public-private partnerships to tell the story at a far more distinct level. So for example, understanding the true scope of what's happening with HIV testing programs in Oakland. We know what's happening with publicly funded sites, but we don't necessarily have the scale and scope of understanding of what's happening in private settings. I think understanding where the epidemic lies in Oakland, as you said, which is in the majority of the flatlands, the West and the East Oakland areas, but also knowing that our testing sites are not centered in those areas, and our clinical sites and our ARV treatment sites are not centered in those areas. And so how to begin to start telling that story and presenting that information in a way that not only do our public health partnerships understand that, but our policy partnerships understand that, so that we can begin to address those kind of disparities.
Great. Yeah, one more, and then we do have an audience member who wants to say
I work in the public health department in Alameda County, and that slide lines the walls sort of everywhere, you know, and we have in our shorthand conversations, we talk about moving upstream. We got to move upstream. Everyone's always moving upstream every day and everything we do. And I think the real challenges we face are that the accountability systems are still very far downstream. So we get a lot of categorical funding for diseases that, you know, streams from the federal government through the state to us, and the accountability is at the level of number of diagnoses made, number of tests performed, things like that. And so it's hard. We're really struggling with resource constraints to be accountable at all, and the only things that we're really accountable to are these downstream measures. And then even if we did have more space to move upstream, as has been pointed out a couple times, the measures are just really hard. It's really nuanced. They change quickly. It's very hard to figure out what are we talking about when we say, you know, social capital, or when we say poverty even. And so it's really hard to develop programs that can use those things as indicators and kind of move forward on them.
Really good point. We had a comment from one of the audience members. The microphone number 1 is yours.
I'm Susan Buckbinder from the San Francisco Department of Public Health, and I really appreciate everyone on this panel. And I was interested in hearing about your thoughts about addressing some of the age disparities that were raised in Dr. Eckert's presentation, and where you think we need additional data and where you think we might innovate to address those disparities. And I guess if you're seeing those kinds of disparities within your environment, so Henry, I don't know if, you know, I know you've been addressing issues of disparities across racial and ethnic groups. I'm also really interested in this issue of poverty, economics, and geography, and how that may play out.
Well, for the first part, I have to clarify if the slide you're referring to was all of California with the age, the 25-year-old group that was rising. I don't think we're seeing that same pattern. I'm looking at Susan Shear behind you. I don't think we're seeing that same pattern in San Francisco. So I'm not so familiar with the age issue there. I have done some work around neighborhood and income, and I alluded to earlier, among black MSM, white MSM, and trans females. And it turns out that in none of those groups did individual level income predict risk-taking. It was whether or not they lived in neighborhoods where there were high concentrations of HIV-positive people. Now, I don't know what the intervention is. We're certainly not going to say, well, let's sprinkle them evenly across the geography. I mean, you can't just relocate people. But maybe the point is that that needs to be put out there, that there are things that are just in the environment that make it more likely for people, whether they engage in higher levels of risk or not, and all these groups are about the same, that, you know, if you're out there doing the same things, if you're in an environment where there are more potential partners that are HIV positive, the likelihood that you may engage in a risk that results in infection is higher. Sadly enough, though, and this is the thing that struck me about what you mentioned about Oakland, in San Francisco, those same neighborhoods, the poorer neighborhoods, are where the agencies serving these populations live, or at least serving this issue of HIV/AIDS, right? And I would love to be able to do like an economic analysis of rental rates and why CBOs are located in these poorer neighborhoods where it seems like they're not that I know they're not serving those residents per se, but they're also in the neighborhoods with the most new infections, right? So I don't know what the disconnect is, and that would be really interesting to take it a step further.
Damon, go ahead.
as a, oh, I'm sorry,
I was
no,
just
go
going to
ahead.
ask Damon, do you know anything about age in Alameda County and if we're seeing those disparities there?
Yeah, I was actually really interested in seeing the state numbers. I think we're still in a phase within our health department where we're re-ascertaining cases and doing a lot of deduplication, and we're looking forward to sort of fall or late summer having a really good, our first, since this transition in 2006, our first really good data. I will say that, you know, at the Downtown Youth Clinic, anecdotally, the numbers of new cases per month have gone from maybe 1 a month a couple years ago to upwards of 10 in some months recently. So anecdotally, we're certainly seeing a lot of new cases, but I'm waiting for the surveillance data to really know.
Also, in response to what we're seeing in terms of age disparities at API Wellness Center in particular, with Asians and Pacific Islanders, we're always, until this day, still seeing men in their late 30s and 40s that are going into the emergency room with OIs and then being linked to API Wellness Center with an AIDS diagnosis. It's their first time testing, or the last time that they were tested was 10 years ago from that ER visit. And so, I mean, this just happened in my clinic just 2 weeks ago. So what we're emphasizing in our testing clinic is trying to emphasize regular testing among young men in their 20s so that they don't get to that point when they're in their late 30s or 40s checking into the ER.
Yeah, I'm not sure this exactly fits in the current panel, but I don't see it anywhere else in the program, and I'm interested in what might be political disparities. I'm thinking especially of some of the differences that I think we've seen over the years in federal funding for HIV programs in the Bay Area, San Francisco versus Alameda County, for example, and the recent possibility of cuts to Ryan White in San Francisco matched immediately almost by the city coming up with additional money, which I don't think probably happens in all communities. And I wonder if anyone can comment on that and whether there are efforts to join forces to try to prevent that kind of disparity. Do people in San Francisco argue for the other Bay Area communities?
I'll make a funny comment. I don't know how the process went about to decide that to drive Ryan White care funding by incidence rates. I believe that's how it was done. So yes, we have a very low incidence rate in San Francisco, and certainly probably lower in the Bay Area than other parts of the country. But that seems to ignore the fact that Ryan White is care money, not prevention money. And it just seems a mismatch to me. So, well, I'm going to call Grant, if he's not here yet. Grant, where are you, to help us do some advocacy at the national level. On the other hand, I do know that other jurisdictions are severely impacted. Like, it's out of control in DC, as mentioned earlier. It's out of control in Baltimore, among MSM certainly. So, you know, I think maybe it is something we have to do on our own now. I think the other parts of the country are really hard hit if we can do it. You know, we are in as you saw from the slides earlier, we have fewer and fewer cases each year. And even the projection of the undiagnosed cases or the unreported cases is getting fewer and fewer each year, at least in the Bay Area or in San Francisco. So, you know, we're in a good place, and maybe being in a good place is not bad, not good politically or good monetarily, but I certainly wouldn't want to be working in Baltimore.
Maybe I'll just answer Paul's question the most specifically I can. And there are probably other people in the room actually know the answer better, but Adrienne McCall from Department of Health and Human Services has actually started a regional collaboration that I know involves our health department and San Francisco's health department. We've also had the good fortune of having the services of an epidemiologist from the CDC who was in the Bay Area for the last year, who's come and really helped us a lot with our surveillance programs. And she was actually assigned to San Francisco, and Grant and Susan were really kind enough to allow her to come hang out with us for a day a week, and she's really done some great work. So there are some on-the-ground collaborations going on, and maybe other people actually in this room even know more about the one that Adrienne McCall is leading.
Thank you. Let's see, microphone number 2, Sally. Yes.
I'm Sally Sloan. I'm from Kaiser in Oakland, and I just have one comment and a question. One is I really appreciate your comment about kind of the incidents having to do with where the people are, communities where they're accessing, where they're seeking sex. And my best screening question for my patients that I care for is, do you go to Steamworks? And if they say they go to Steamworks, I can guarantee you there's a 50% chance their STD screen will be positive, and if they say no to me, it's highly likely they'll be negative. And I can't say that that mimics our new cases, that's where we don't ask that question of every new diagnosis, but I think that just as far as assuming that the STD incidence is tracking the HIV incidence, that has a lot to do with it. And the question I have is, you know, I think what you said about the disparity kind of being a moving target is true, and we had recognized that our female population was not really accessing the services that we were offering 15, 18 years ago, and we did a very intensive program to try and understand, including surveys and focus groups, and changed our model of care for women. And now, you know, we have 100% show rates for appointments. And the population that I'm really struggling with are the refugee immigrant population. And I've asked this question from many individuals, and I've never gotten any good guidance of how to approach that population. Many of my patients have never told anyone that they're living with HIV. They refuse all interpreter services. They come to all their appointments, they take their medications, generally they have good virologic control, but they are completely isolated, lonely, and it's a huge, huge problem, and I don't know how to deal with it. And it's different from all of the disparities that we've addressed very successfully in the past.
So first I'll say, isn't it kind of funny that after 30 years we've come back to bathhouses? Cindy's nodding her head. I guess it would depend on what recent immigrant populations you're talking about. I certainly know the API Wellness Center does a lot of work with immigrant folks who are...
Mostly the Ethiopian population, I have to say. I saw 3
Ethiopian
patients yesterday morning,
okay.
taken care of from years, and none of them had ever told anyone.
Anybody in the audience can help out here?
They don't want peer mentoring, they won't go to support groups. It's a big challenge. It's not just those the Ethiopian, but Burmese, Ethiopian. We do partner with the Asian Pacific Services in the East Bay, but many of them don't want to go there either.
Maybe there's...
We do, and if they see our Ethiopian receptionist, they won't come to their appointment. They come to the door and they see him there and they reschedule.
Yeah, absolutely.
The question was whether you had Ethiopian staff, just for the audience.
Yeah, that's a tough one. I don't... Sorry, there you go. You get another non-answer again.
The point is, you said, you know, the population, the disparity changes, and we need to come up with more innovative ways of addressing it that are different from how we've addressed disparities in other populations.
You're with Kaiser, I'm sorry? Yeah. I definitely think that establishing really strong partnerships with community-based organizations would definitely help in approaching the community, because I think an institution like Kaiser can look kind of intimidating, I think, for recent immigrants or and for us at API Wellness Center. Just, I guess I don't know, there's something culturally about API Wellness Center that's more approachable to recent immigrants. And I think, but you said that you've partnered with Asian Pacific American Services already? Okay.
I think the other thing that should happen in that case is that as we're, again, looking at the changing face of HIV/AIDS, we have to look at the changing face of our demographics as a whole. And looking at the changing face of the demographics as a whole, and then looking at our healthcare delivery system. Do we have the right people sitting at the table? Do we have the right individuals? And so if we know a little bit more about that culture, the receptionist may not be the appropriate person. So the question would be, as we begin to look at the pipeline as a whole for healthcare providers, working with the communities, you know, are we making the right relationships? You know, what is the role of faith-based organizations? Where are they at the table? Should they be at the table? So beginning to look at some of those questions might be something that we need to address in looking at healthcare disparities as well.
Great issues. Microphone 1.
Hi, Elise Riley from UCSF, and I wanted to get back to some of these, the issues around disparities not being necessarily just a function of income, but of communities perhaps where you live. With our work among HIV-positive homeless women, we've definitely found that it's not just a matter of income. As a matter of fact, total income is never a significant predictor of health status or health services use. It's more about unmet subsistence needs, and it's more about the upstream factors. And getting back to this idea of upstream factors, right now it's very interesting to me that our social programs are under attack politically. And in terms of research, when we apply for funding at the NIH to try to get money to research social determinants of health, it's really, really challenging. And there's kind of a standing joke among a lot of my colleagues, and I will just throw in an assay for genetics or put in something with a brain scan and you'll be fine. But there seems to be less funding to just look at social determinants of health. And there's a lot of controversy politically around social programs. And so, of course, this is really challenging, and it seems like a lot of us are on the same page that it's these upstream factors. And I'm wondering if any of the panelists have seen what's working in terms of community-wide or issues around politics. Like, what suggestions might you have from your work for ways that we can address this, ways that we as providers and researchers and advocates, what are some strategies that we can be thinking about or start having dialogue so that we can help bring more consciousness to this? Thanks.
We've kind of been at the same game in Alameda County for a while, and we've really just hammered the language and that framework that Dr. Gomez put up earlier, and we were really delighted. The last budget meeting at our Board of Supervisors started with 5 slides that were all about the social determinants of health in our county with county-specific data. And really, the supervisor who was running the process used our framework as an opening to the budgeting process within our county. So I think it's just, this is going to be years of work, but I think it's going to be just hammering that same message until the grants start looking different at that level.
I also think it's more too also around what Dr. Gomez said in terms of creating this paradigm shift in terms of the methodologies that we use to start to measure these social determinants. And I think we've heard a lot, obviously, at the global level around the use of implementation science methods, and really that those are methods that are just couched within public health frameworks that we already are using, but how to embed those methods in the action of doing work. So that combination of working at the community-based level, working at the clinic level, working to actually do the work at the same time as measuring what it is that we're doing, and starting to begin to change that paradigm shift around what research methods can actually measure. And the gold standard of the RCT is not going to work to determine what these social determinants are and what they're actually doing in our communities. So really starting to have that kind of framework, I think, as well, is really important for all of us as researchers, as communities, to start to get people to shift towards, to move into.
Thank you. Microphone 2. Yes.
Yeah.
And this may be our last question. We'll have one more question, but we will stop at 10:20.
Hi, my name is Malcolm John from 360 Positive Care Center at UCSF, and I want to thank you all for your expertise and sharing your perspective. I think it's, one is a comment, it's increasingly clear that health inequity and disparities is very regional as well as national, and it's evolving, as you pointed out. But I do want to raise a point that when you look at CDC data in terms of clinical outcomes, say for African Americans with HIV as far as 9 years out, they still Americans, for which the latter group, for which numbers are very small, as far as 9 clinical outcomes, and we need to address the factors there. So having said all of that, a comment about being conscientious in your innovation. And I'd love to hear from the group, or start to hear from the group, because I think one of our main purposes here is to find out how we do that and examples of that. So I'd love to hear from the audience of examples of conscientious innovation that's going on.
Hi, I'm Carly Dillard-Smith from CalPEP. I was touched by the speaker on the end who talked about how to engage community to access testing. And I just wanted to share the experience that we've had at CalPEP since 2004 as a community-based organization. The funding has totally shifted, and community organizations are totally stressed. And as we look to the shift to test and treat, what's happening with community-based organizations that do HIV work in Oakland, we have to become clinics in order to survive. We can't continue to survive on grants, because under the Bush administration, the competition for funding was opened up to everyone. So when we compete, we lose. So we're not getting that funding. I agree, and we've known this, and research has shown that where the HIV positive cases are is where people are. It's in the community. And we don't have the capacity to reach them any longer. We aren't bringing in the kind of HIV positive numbers, even though we know 20% of the community out there has it. And again, it has to do with shift in policy. So I agree with the person who says we need to include in this discussion policy disparity. And what I mean by that is, under the Bush administration, a lot of the funding that we received was shifted to the evaluation system and evidence-based interventions, and a computer system where they spent millions of dollars and it doesn't work. So in order for us to reach HIV positive, we need the ability, again, to do outreach, to staff people to do that outreach. It's very simple. And we understand that, you know, we're way beyond individual level interventions, but we're not in a position to get the testing where it's needed right now.
Those are really great comments, and I think to be thinking about as the break comes up. I want to just stress the importance of, we've talked about moving upstream, and the nice thing about this is we don't all have to move upstream. A number of the upstream people are among us in a collaborative meeting like this. So I think this is the chance, I think, that we have to be talking at different levels during the coffee breaks and in the discussion sections. So I want to thank the panelists for being here, and thank the audience for your participation. They've asked us to stress that the break, which is happening real soon, will be in the foyer area. The posters are back in the back of the room here, and we will begin again at 10:50.
Super. Thank you very much. So thanks to the moderators and the panelists. I think this was exactly what we were looking for, a very interactive discussion. And as you just heard, there is a coffee break. Use the opportunity to start looking at the posters, but also really use the opportunity for networking and getting to know people that you haven't seen before. And the next session after the break is on testing and linkage to care, and the moderators will be Malcolm. I would ask that they then just come up after the break and introduce themselves and get the session started. So this was great. Thank you very much.